Hello sir, magsulat sa ato ang session karon. So akong buhaton first is range of motion. So with this, I will be testing if naa pa kay limitation of motion sa imong angle ng movement. Okay, so mag-start with ankle dorsiflexion. So ang kanang action is I will instruct you to bend your ankle towards the ceiling. So bend at pataas. Okay. So normal. Sige. Sir, what I want you to do is to bend your ankle towards the ceiling. Ready? 1, 2, 3, go. Bend. Okay, more makaya sir. Okay. Okay. So next, move on ta sa ankle inversion. So for ankle inversion, atong i-down lang atong ankle, ito straight na. Okay, so what I want you to do is to bend your ankle inwards, pasulod. Itong paana. So ready? 1, 2, 3, go. Pasulod. Ana. Okay, very good. Sige. Next is, I want you to opposite atong action sa pagawas. Okay. Straight, normal lang ta. Ready? 1, 2, 3. Okay, pagawas sir. Pagawas. Okay. Okay, thank you. So, it was noted that patient has limitation of motion as to ankle dorsiflexion, inversion, and eversion.
I want you to raise your right toe towards you. Your foot towards you. Okay, very good. Now I want you to turn it in. Inside. Pana. Okay, outside. Okay, very good.
So next, sir, atong matrix muscle build test. So this will identify if naba kay atrophy sa imong muscles. Specifically sa imong foreleg muscle sa imong foot na muscles. Atrophy meaning version ni gamay imong muscle, okay? So nakita. So, finding the largest muscle group. Okay. Sige, sa foot na sir. Saka lang naman. Okay. The other side ta. And normal na. So, sa iyang largest muscle group. Okay, sige saka. Okay. So it was noted that patient has atrophy sa iyang foreleg muscles and sa iyang foot na muscles.
Now for the sensory assessment, first we'll assess for the sharp and dull discrimination. So this is sharp and this is dull, okay? Tell me if it's sharp or it's dull, okay?
Sharp, dull. Sharp, dull. Sharp, dull.
Okay, close your eyes.
Sharp, dull. Sharp, dull.
Okay, so now this is for the light touch. So this is how you're supposed to feel. Say yes if you can feel it, okay?
Yes.
Okay, close your eyes.
Yes.
Okay, so now let's just assume that this is hot and this is cold. So this is hot and this is cold, okay? So tell me if it's hot and tell me if it's cold. Okay.
Hot, cold.
Okay, very good. Now for the kinesthesia. So muna siyang up, muna siyang down, muna siyang in, muna siyang out. Okay? Saan siya?
Up, down, in, out.
Close your eyes.
Up, down, in, out, in, up, down.
Okay, so open your eyes. So now I want you to so this would be vibration. So this is what you're supposed to feel. Okay, say yes if you can feel it, okay?
Yes.
Okay, close your eyes.
Yes.
So now for the 2-point discrimination, so tell me if you can feel 2 or 1, okay?
Two. One.
Okay, so it's about 1 inches ang iyang difference and you can feel 1 already. So next would be for the graphesthesia. So tell me what shape I'm gonna draw, okay? So open your eyes up.
Triangle, circle, square, triangle, circle.
Okay, close your eyes.
Triangle, circle, square.
Okay, tell me if you can feel 1 or 2 and indicate which side you feel it, okay?
One left.
So next, sir, is coordination assessment. So with this, I will be testing for your lower leg na coordination. So first na button is toe to therapist na finger. So what I want you to do is using your toe, touch ni nga finger ha. Sige, ready? Touch it already. 1, 2, 3, go. Very good. Okay, pitas pod. Okay, here. Okay, here. Okay, next coordination, sir. Ang assessment na button is heel to shin. So what I want you to do is using your heel, I want you to slide it across your shin. Okay? Sige, sasa lang kayo. Ready? 1, 2, 3, go. Okay, very good. Pitas pod, sir. Okay, one more time. Ready? Okay, another. Okay, sige. Next is tapping of the foot. So yung button, sir, is mag-anak. Okay. And pitas pod, sir. Okay, another anak pod. Okay, okay, very good. So it was noted that patient has impaired coordination as to the lower extremity, specifically sa iyang touching the toe to therapist finger, heel to shin, and tapping of the LB.
Now we will assess the static and dynamic balance of the patient. So the patient is easily tipped down and unstable when walking. Upon assessing the posture of the patient, she presents with right foot drop.
So for gait assessment, the physical therapist will be assessing the patient's gait pattern while the patient walks.
Ma'am, so these are the things that you should avoid, okay, when you're at home or at work. So you avoid crossing your legs or putting long-term pressure on the back or the side of your knees, okay?
Okay.
Avoid environmental clutter to reduce the risk of tripping. So you need to clean your surroundings so that there will be no objects in the floor that would put you to...
So for the special test is the nail sign. So the therapist will be tapping along the course of the nerve, specifically sa iyong tubular neck, and when ini-tap, the patient will feel pain. That is indicative of peripheral nerve injury. So, tap, sir, ha? Sir, na-feel na pain? Yes. Yes, okay. So that is indicative, that is a positive nail sign.
Raise the affected limb and invert the foot. Saan mo na-feel, ma'am?
Nanakurente.
So, sir, muna itong first na buhaton for our kanang plan of care. So, what we're going to do is let's create the education program for 10 minutes using brush and sharp pin and also finger for pressure. So, atong buhaton, sir, is mag-stimulate ko using mga different types of materials para magbigay ang sensory sensation sa patient and also their sense of their environment. So, mag-start ako, sir, ha? So, muna siya ma-feel na pain. Okay, next is brush for light touch and finger for pressure. Okay, so that will be done for 10 minutes.
For tens, place the electrodes on the dorsum of the foot and just above the lateral malleolus. Set the frequency to 80 Hz, pulse duration to 30 milliseconds, and intensity of 3 milliamperes for 15 minutes.
Next is NMS with at the shins with a pulse duration of 10 ms with a pulse interval of 20 ms, and then the intensity will be gradually increased. So this is done for 10 minutes to facilitate muscle contraction and also to improve patient's muscle performance. So, ito yung sir, okay, so ako i-put ang parameters. So, sir, ako mag-feel na sensation, okay? Yeah. Okay. So, na-feel na mo, sir? Yeah. Okay. So, ako i-increase kamay and pag-tawag mag-start na contract or mag-move yung okay? So, okay now. Okay. Okay, very good, sir. So, that is for NMS.
For the peroneal nerve glide exercises, in a supine position, flex the hip to 90 degrees. Extend the leg and invert the foot. As the leg is lowered to the start position, flex the neck forwards towards the chest, then straighten the back to the floor as the knee is extended and inverted. For the active range of motion exercises, we will do the ankle alphabets. So, using the foot, draw letters from A to C, and this is done for 1 set.
Next exercise is stretching exercises for 5 reps, 2 sets, and 30 seconds hold. This will be done in order to improve range of motion and to prevent further contractures. So the first two exercises is plantar fascia, standing calf stretch, and also standing soleus stretch. So what you will instruct the patient is to, using the wall for support, the starting position will be that the unaffected leg is at the front and the affected leg is at the back. So you instruct the patient to lean against the wall using their chest and to bend their unaffected knee, while the affected knee is straight line. So ready? So I want you to lean towards the wall, like that. So this will be done for 5 reps, 2 sets, and 30 seconds hold. So for the standing soleus stretch is the same gapon na starting position wherein the unaffected leg is at the front and the affected leg is at the back. So ganina is you bend one knee, but this time for the standing soleus stretch is bending both knees. So I want you to lean towards the wall and both knees naka-bend. So do this for 5 reps, 2 sets, and 30 seconds hold. Next stretching exercise is towel stretching with the patient in long sitting and then putting a towel around their affected foot or the toes, and then you instruct the patient to pull towards the body. So you will be doing this for 5 reps, 2 sets, and 30 seconds hold.
Progressive resistive exercises using the orange TheraBand. Wrap the TheraBand around the sole of the foot and pull the TheraBand towards you. Bend your foot inwards. Then outwards. And this will be held for 5 seconds, 5 reps, and 3 sets. Gait training is done in parallel bars with AFO, so let's just assume that she is wearing an ankle foot orthosis on her right foot. And this is done for 10 rounds. For the functional training, raise your toes off the ground. Do this 5 reps and 2 sets. Lift the ball using your feet. Do this for 5 reps and 2 sets.
Other management include the use of AFO to provide toe dorsiflexion during the swing phase, median or lateral stability at the ankle during stance, and if necessary, push-off stimulation during the late stance phase. Patient education includes patient is educated to avoid crossing legs or putting long-term pressure on the back or side of the knee. Patient is educated on activity pacing, and patient is educated on proper body mechanics and positioning changes.
You need to avoid crossing your legs or putting long-term pressure on the back or the side of your knee, okay? Especially at work, so avoid crossing your legs. And at home, you should avoid on your floor, clean your environment so that there would be reduced risk for tripping or falling. And at work, if possible, avoid wearing high heels. Use flat shoes instead.
Okay.
So when you come across with a patient who has the peroneal nerve injury, these patients usually have a job that would require them to wear high-heeled shoes or tightly laced shoes. So tight-fitting shoes compresses the nerve beneath the extensor retinaculum. So this commonly occurs while wearing tight ski boots, so it is called ski boot syndrome. So those women who wear high-heeled shoes or individuals who sit with plantar flexed ankle, which is usually prolonged pagyod, can also develop neuropathy of the peroneal nerve. Hindi na kumasa ka mo. So ako kung bato lang nila nila kay gana. Mura man siya kahabilin. Diba, sakit man na diri. Diri. Ani grabe gid kayo kagabian ni sakit gihapon kini diri dapit. Wala na makaya na kumasa ka mo. Hindi na kumasa ka sa tibok. So HPI usually what happened man gyud extrinsic maybe as I said a while ago, there was a compressive shoe wear, kanang wearing tight laced shoes. Previous history of fracture example is spiral tibial fracture, trauma, kay repeated dorsiflexion and plantar flexion, which contributes to the pinching of the peroneal nerve. We have the recurrent ankle instability and the surgical procedures about the lateral knee. So intrinsic kay kuan, it is caused by the kanang problem with the tibial and talonavicular joints, kanang deformities such as pes cavus and post fracture, tendinitis, and even hypertrophic muscle belly of the EHL, EDL, or tibialis anterior. And we also have kanang it may be caused by the ganglion, cyst, tumors, peripheral edema, and etc. So those patients who have been diagnosed with chronic anterior exertional compartment syndrome, those athletes who were diagnosed with this one usually have the peroneal nerve problems. So for the lifestyle, those patients who love to play who do skiing, who do snowboarding, those wearing high heels, those mga a sales lady, those people.
So for the observation, the patient presents with a foot drop when he swings his leg while walking towards the treatment room. So during palpation with distal entrapment, there is tenderness over the anterior ankle or just distal to it. During the neurological assessment for the sensor assessment, there is pain on the dorsum of the foot, dysesthesia and paresthesia on the dorsal foot, wherein the lateral hallux and the medial second toe in the first web space are the most common locations of these symptoms. We also have decreased 2-point discrimination in the lateral hallux, decreased 2-point discrimination in the medial second toe and the first web space.
Hindi ko ma-feel. Sige mama, close your eyes ma'am. Nasa mot, wagid ko. Samot, wagid. Banduha daw, ma'am. Okay. Oh, wagid. Wala gid.
For the range of motion, we have a loss of motion in the ankle dorsiflexion and inversion. We also have a loss of motion in the big toe dorsiflexion. We also have the patient complaining of pain during the ankle plantar flexion ROM assessment.
Sakit, sir? Wala ni pinakaya mo?
During the manual muscle testing, the patient would experience weakness on the ankle dorsiflexors and big toe extensors.
Hindi mo kaya? Sige, sir. Try na ito. Nanay is support ka, sir. Sige, sir. Saka. 1.
There is also a dramatic foot drop upon ankle plantar flexor during MMT assessment. So for the MBT, there is usually an atrophy on the extensor digitorum brevis.
Gamay ganda siya dirigyot. 22 compare na itong usap, 25.
So our next assessment will be your balance assessment. So obviously, sir, this is to test your balance. So we have 3 parts. You're sitting, standing, and you're walking balance. So the first one is sitting. So if you have planning vehicle, sir. So for this, 1, 2, 3, 4, 5, 3. And next part is of course, make sure that pumping is okay. 1, 2, 3. So next part is your balance assessment. Okay, so together, okay, 1, 2, 3, 1, 2, 3, 30. And the next one, from here, 1, 2, 3, go. Next. Okay, so next, balance assessment, you want to from here to that, okay, 1, 2, 3, go. Okay, thank you so much. Patient is impaired static dynamic balance as to walking and standing. So our next assessment is coordination assessment. So the first is foot tapping. So okay, next one is so the patient has impaired lower extremity coordination owing to the weakness of the right foot. Assessment is our gait assessment. So what I want you to do, sir, is walk from this point to that point, and then that point, and then back here. Okay? Okay, sir, just very difficult. So, and then I'm walking. So, above and down. Go, sir. Upon gait assessment, the patient presents with the right foot drop upon swing phase of the gait, and there is a crunch gait. So the next part, sir, is your functional assessment. So I'll be asking you a set of questions regarding some daily activities and gait. And pag-asa ka ng liso tungkol sa inyong right foot, okay? Okay, so this is sir. Doon, ligo, sir. Ilis, sir. Okay, pag-ilis natin mo, kanang legs, sir, kanang pants, kanang ka. Yes. How about going to the toilet, sir? Okay, you have a bladder, kanang dysfunction, magisod ka init, bowel dysfunction. So magisod ka o go tayo mag-bed, sir. How about going to the shower? Yes. How about walking up and down the stairs? Yes. Magisod ka communicate, no wrong answer. How about interacting with people? How about solving problems, sir? No. How about your memory, sir? No, wala. Hindi na kamakalimot. Okay, so that's the end of our question. So patient reports difficulty in performing activities involving standing and walking, especially ambulation, transfers, and lower extremity dressings. So sir, we will be doing a special test called your Donnell sign. This is to check if kanang involved sa imong problems in your foot is your peroneal nerve, which usually hindi na natin sa foot. Okay sir, so tap lang ako siya for 30 seconds, okay? Okay, so patient presents positive Donnell sign, which means that the peroneal nerve is involved in his complaints. There are also other tests and measures that is used to rule in or rule out the peroneal nerve injury. First is your electrodiagnosis, the most helpful test to evaluate foot drop. Next is your electromyography, the less impulse reaching the nerves innervated by your peroneal nerve. The next is the nerve conduction velocity study, impaired impulse velocity in the distribution of your DP and or the deep peroneal nerve. And radiographs in the lateral view of foot and ankle to check for ocular formation and fractures. And lastly is your MRI, best evaluation for mass lesions. The problem list for peroneal nerve injuries are pain on the dorsum of the foot, impaired sensation on lateral hallux, medial second toe, and first web space. Foot drop, loss of motion on ankle dorsiflexion and inversion and hallux dorsiflexion, weakness on ankle dorsiflexors and big toe extensors, atrophy on the right extensor ditorum brevis, impaired standing and walking balance, impaired lower extremity coordination owing to the foot weakness, slippage gait, and impaired ADLs such as standing and walking such as ambulation, transfers, and lower extremity dressings.
Let's do the conventional tense wherein our pulse width is 50, the frequency is 50 po. The human electrodes are placed anteromedially on the volar surface of the lower leg, inferior to the patella, and also in the dorsum of the foot. So we have this auxiliary education exam. Assuming these are the tools that we are going to use, the hot and cold, the katong 2-point stimulation, the pain, the katong soft brush. This is assume long sitting position. Let's use this koan. Let's scoot forward to have a koan kanang footboard, somewhat like that, so that the foot would be or the ankle would be maintained in dorsiflexion. We'll always use to reference gini ang normal. So una kita sa normal sige. Yes. Parnay ko niya yung footboard para ma-maintain into dorsiflexion. So, ang magamit kay dirigid na muscles. Huwag katong gi-innervate sa deep peroneal nerve. Karon, mag-contact calf stretching by placing a small roll towel. Let's place this one. Okay? Okay, na. So, yan na. Naka-dorsiflex ng foot at the same time kay ma-stretch ganyan na to ang plantar flexor. So, we will dito sa i-rom. So, i-rom ani, what we will do, kay tungod kay kita naman usa, so we will do some adjustment. So, unaan na kay dorsiflexion man, gamiton kaya pa na to ang kani atong ana. Kaya naman imo plantar flex na imuha lang, plantar flex na pero nagya pa footboard. So, palayo tagamay para dili lang ta palabi na plantar flexion. Importante kay nakastimulate ang plantar flexion ha. Para di siya sakit. Kani, kay manamtag plantar flexion, dili na punta. Pwede na ito nibutgan. Hindi lang gid siya kay di gamay man. So, atong pula ni gamay ra gyud. Importante malihok yun siya.
Sir, so for this exercise, we'll be doing a strengthening exercise of your ankle dorsiflexors using a green TheraBand. So we'll be doing this exercise for 8 reps, steps 2 sets to improve your ankle dorsiflexors and great toe extensor strength. Okay, sir, so our next exercise is your coordination exercise for 10 minutes on both of your legs. This is to increase your lower extremity coordination in preparation for functional activity. So first one, sir, is your bilateral heel raises. So I want both of your foot in hand sir. So one of the heel raises. Okay, first and bottom. So 8 first one, so we go 1, 2, 3, 4, 5, 6, 7, 8. Next is your toe release. Toe on so like this. 1, 2, 3, 4. 5, 6, 7, 8. Okay, next is your bilateral lower truncated angle. Okay, so that is your one count. Okay, 1, 2, 3, go. Ready? So, this time, sir, we'll be tapping to isang 2 minutes on. Go. Dali go. Dancing with. Okay, 1, 2, 3, go. You can dance, you can dance, dancing with angle, dance. Ooh, you can dance, dancing with. Okay. Okay, so our next exercise will be your balance exercises within a parallel bars for while wearing your ankle foot orthosis on your right foot to prevent the foot drop. So this is to improve proprioception, balance, and tolerance for functional activities. So first is your double forward standing. So still in a parallel bars and wearing the ankle foot orthosis on the right foot, the patient will be doing a gait training for 20 feet 2 sets to facilitate normal gait pattern for performance of the So the next part is a functional training, still with your ankle foot orthosis on the right foot for 8 reps, 2 sets each exercise to facilitate ankle mobility and performance of AD health. So still 8 reps, 2 sets. So ito na 1, 2, 3, go. Taro lang. Hindi mo please. Ano sir? Balik. So for additional PT management, so we will teach the patient different things. For patient education, first, the mechanism and presentation of occurrence of pain and condition, proper donning and doffing of the ankle foot orthosis, proper wearing of the ankle foot orthosis for the foot drop to provide adequate dorsiflexion and facilitate a normal gait pattern. We will also advise the patient different shoe modifications to facilitate normal gait function, like lowering the heel, wearing a well-padded thumb on shoe, alternative lacing configurations, full length rocker sole, steel shank, and then another is proper skin care for the lower leg and foot, precautions for the injury, like avoid repetitive activities involving the ankle joints, avoid wearing tight shoes, and proper lacing techniques. Good afternoon, Miss. My name is Dulcie Marian Casanova, and I'll be your physical therapist for today. So, Miss, may I know your name?
Samantha,
Okay, so Miss Samantha, how old are you?
33,
Okay, so may I know your occupation, Miss?
professional athlete, volleyball.
Oh, okay. So, what brings you here today, Miss? Do you have any complaints or anything?
Pain, numbness, and tingling.
Sa which area man, Miss?
Here sa foot.
Oh, sa imong dorsal sa imong foot. Okay, so what were the events there, Miss? Or what happened that led to the condition that you're having right now?
While I was playing, ni jump pag maayo niya. Paglag ako sa ground, kaya ako na-twist akong ankle. Mo na naka-ankle sprain ko.
Then, what did the doctor say man, Miss?
Na-twist akong nerves.
Okay, so, do you have any medical history, Miss? Or do you have any conditions? Conditions?
Diabetes.
Okay, so were there any tests done, Miss, to confirm the diagnosis?
EMG.
To test the electrical activities in mga muscles, Miss, no?
First would be ankle eversion, asking the patient, "Ma'am, I want you to move your feet towards the sign." In this case, it is towards the right, and it doesn't seem to be that way because the video is a mirror of what I am doing. I want you to move to the right as much as you can, ma'am. Okay, that's it, ma'am. Then next would be for plantar flexion range of motion. So, ma'am, I want you now to move your foot downwards as much as you can. Is that all you can do, ma'am? Okay, that's good, ma'am.
Right now, Miss, I'll be testing your muscle strength to know whether or not by any weakness. Okay, Miss? Sige. What I want you to do, Miss, is I want you to point your toes downward and outward as much as you can. There, ako to, Miss?
Yes.
Okay, so right now, I want you to try and match my resistance, Miss, ha? So don't let me push your toes up and inward, okay?
Okay.
1, 2, 3, go. Okay, so after testing, kay it shows na you have some poor muscle strength, kay limited ang range of motion, and you can't tolerate any resistance.
Next would be for muscle bulk testing. So first palpate for the muscle belly of peroneus muscles. Then measure the circumference. In this case, centimeters was used. Make sure that both lower extremities are to be assessed in order to compare if there would be a significant difference. But for these cases, there would be significant difference, especially for severe cases of this injury.
Okay, so right now, Miss, kaya we'll be doing some sensory assessment. This is for me to know whether or not may mga abnormal sensations, specifically sa imuhang lower left leg and sa imuhang dorsum of your foot, okay? Okay, open your eyes lang sa Miss ha. This is the sharp and this is the dull. Do you feel that, Miss?
Yes.
Okay, so tell me whether it's sharp or dull. 1, 2, 3, go.
Sharp. Dull. Sharp.
Okay, now I want you to close your eyes and tell me whether it's sharp or dull.
Sharp. Sharp. Dull. Sharp. Sharp.
Okay, right now, okay, I want you to tell me whether you feel any cold or hot, okay? So I have here 2 test tubes. This is the cold and this is the hot. You feel that?
Yes.
Okay, now I want you to close your eyes and tell me whether it's hot or cold, okay? 1, 2, 3, go.
Cold.
Close your eyes, Miss.
Cold. Hot. Hot. Hot.
Okay. Right now, I want you to say yes if nakafeel ka any soft. Okay? Now, close your eyes and say yes if nakafeel. Okay? 1, 2, 3, go.
Yes. Yes. Yes.
Okay. Right now, I want you to say yes if nakafeel na pressure, Miss, ha? 1, 2, do you feel that, Miss? Open your eyes and do you feel that?
Yes.
Okay, now to close your eyes and say yes if nakafeel na pressure, okay? Go.
Yes. Yes. Yes.
So it shows, after testing your sensory, it shows na you have impaired sensation, specifically sa imuhang lateral aspects sa imuhang lower leg and sa imuhang dorsum sa imong foot.
Next would be coordination assessment, assuming I'm the patient. So ma'am, follow my index finger with your index finger. Then follow it after pointing to your nose. And now this time, ma'am, follow it or point my finger with your toes. That's good, ma'am. Okay. Make sure that this is to be done in both hands and both feet. Now tap on your hand, on your lap. Then I want you to tap your feet now on the floor. Okay, that's good, ma'am. Next would be for equilibrium. So I want you to sit comfortably. And now weight shift in all direction or side to side, front, back. Just follow me, ma'am. And now I want you to point your fingers or point your hand in different directions. Just follow me, ma'am. Just follow my suit. Okay? Okay, that's good, ma'am. Forward. Okay. Now I want you to stand comfortably. Okay, and now follow my hand again. Move it in different directions. Just follow my suit, ma'am. Okay, that's good. Okay. Okay.
Right now, Miss, kaya let's test for your balance and tolerance, Miss, ha? Okay, so first, kaya stand lang with both feet on the ground. Okay, now I want you to follow me and put your left foot in front of your right foot. Okay, now I want you to stand only sa imuhang right foot. Stand on your right foot. Okay, now sa imuhang left foot. Okay. Okay, thank you.
Next would be gait assessment, assuming that the affected leg here is right leg, and it doesn't seem to be that way because the video has mirror effect. So there is the podge gait notice while the patient is walking because the patient's right foot has inability to lift the toes from the floor, so there is foot drag during swing phase. Next would be functional assessment, specifically mobility, transfers, and lower extremity dressing. So just ask the patient his usual routine at home, so transferring to the bed, and bed to chair or bedside chair, and then putting on pants, donning and doffing the pants. This is usually assessing for the usual daily routine of the patient if there would be any impairments, and there is really be decreased ability, possibility, high tendency because of affectation of one leg.
Next, Miss, I'll be doing the tinal sign test. So, mag-tap lang po or percuss yung mukhang lower leg and I want you to tell me whether you feel any abnormal sensations. Okay, Miss?
A.
Ano feel, Miss? Yes, tingling sensation sa akong outer lower leg and sa front sa akong foot. Okay, so positive for the tinausa. So after all the assessments, kaya it shows na patient has a pain on the dorsum of the foot, decreased sensation and numbness specifically sa lateral aspect of their lower leg and dorsum of the foot, decreased range of motion on foot eversion and ankle plantar flexion, weakness in peroneal muscles, atrophy of peroneus longus and brevis of the affected lower leg, impaired coordination as to non-equilibrium and equilibrium, secondary to weak peroneal muscles, impaired static and dynamic balance during one leg stance, impaired tolerance during one leg stance, and impaired gait, and lastly, decreased ability to perform functional activities as to the lower leg dressing, transfers, and mobility, secondary to weak peroneal muscles. So for the plan of care, the patient will be wearing some ankle-foot orthosis to support the joints and also assist the weak muscles. Next, conventional TENS. So for the parameters, 50 microsecond, 50 hertz for 20 minutes. So this, we'll be doing some TENS. And this is to relieve the pain that you're feeling sa inyong lower leg and increase the tissue extensibility in preparation for the activities. Okay, miss? So I'll be placing the electrodes just below the patella, so anterolateral of your leg and the dorsum of your foot. So, take a look at miss. So, okay, so, miss, before we start, I'd like to remind you lang, don't touch the electrodes, miss, ha? Start na to, don't do unnecessary movements, and just tell me if you feel any, uncomfortable sensations, okay, miss?
Okay.
Start na, miss, ha? So, ako lang gradually increase ang intensity, and then, tell me if mawala na ang pain, yung mohang na-feel, and ang mabili na lang kay ang current or electricity, miss, ha? Don't worry, dili na siya sakit yung kaay, okay? Nawala na ang pain, miss?
Yes.
So, assuming 20 minutes is done, so, miss, ako na-remove, miss. Okay, right now, miss, we'll be doing the sensory education training. So, this is to improve your sensation and also improve performance when doing the activities, especially when you receive tactile cues, okay, miss? So, I'll be using the sharp pin for pain, and then 2 test tubes for hot and cold, and then brush for light touch, and then my finger for pressure, okay? So, we'll be doing this for 10 minutes. Okay, miss, let's start. Okay, feel that, miss?
Yes.
Okay, this is the sharpness hat. So, we'll be doing this for 10 minutes. Next, okay, this is the cold. You feel that?
Yes.
Okay, so we'll be doing this for 10 minutes lang gihapon. Improve your sensation for cold. Shooting time is done. Now, this is the hot. You feel that?
Yes.
Okay, so doing this for 10 minutes as well. Next, this is light touch. Do you feel that, miss?
Yes.
Okay, we're doing this for 10 minutes. And lastly, this is for pressure. Do you feel that?
Yes.
We'll be doing this for 10 minutes as well. Next, miss, we'll be doing some assisted active range of motion. So this is to improve your mobility or range of motion in preparation for strengthening exercises and functional activities, okay? Okay, miss? Okay, so we'll be doing this for 8 reps and 2 sets. So first, what I want you to do is, please turn your foot outwards. As much as you can, miss, ha? There ako to?
Yes.
Okay, stretch, miss, ha? Again. Assuming 8 reps and 2 sets is done. Next, what I want you to do is point your foot or toes downward. As much as you can, miss. Here ako to?
Yes.
Again. Assuming 8 reps and 2 sets is done. Next, miss, we'll be doing some strengthening exercises with this TheraBand. So we'll be doing this for 8 reps, 2 sets, and 5 seconds hold. So these exercises can help improve your muscle strength para improve yung performance, especially during the exercises later on. Okay, miss? Okay, let's start first kay plantar flexion. So what I want you to do is point your foot or toes downward and hold that for 5 seconds. Assuming it's done. Next, I want you to point your foot and toes upward. Hold that for 5 seconds. Next, I want you to point your foot inward. 1, 2, 3, go. And lastly, point your foot and toes outward. Okay, 1, 2, 3, go. As much as you can, miss. And then hold this for 5 seconds.
Next would be coordination exercises. First off, toe to heel rocks. So, 5-second hold for toe and 5-second hold for heel. So this seems fast, but this is just to give an overview as to how it is to be done. So next for the coordination exercises would be kicking a ball for 3 sets, 10 repetitions. So just ask the patient, ma'am, can you kick this ball? Okay, just follow it and then kick it. Then next for coordination exercises would be sidestepping over a series of blocks. So ask the patient, ma'am, I want you to sidestep making sure that you skip the blocks. Okay, and this is done for 3 sets, 10 repetitions. Next would be balance and tolerance exercises on parallel bars with an ankle foot orthosis for 10 minutes. So assuming that that knee sock is an ankle foot orthosis. So assuming that those chairs beside me are parallel bars. So first would be double support standing perturbed, then tandem leg stance, then tandem leg stance perturbed. So assuming I am being perturbed by someone else, my center of gravity is being disturbed by someone behind me. Then after the tandem leg stance would be single leg stance, an unaffected leg, then affected leg, then perturbations for single leg stance. So assuming again that someone is giving me perturbations. Next would be gait training on parallel bars with an ankle foot orthosis for 2 sets. So assuming that that knee sock is an ankle foot orthosis again, and those chairs beside me are parallel bars. So just ask the patient to walk at his normal speed. Just walk and walk. Next would be functional training in a closed environment as a lower extremity dressing, transfers, and mobility for 10 minutes. So just ask the patient to do his usual routine and just guide the patient. And if there would be any mistakes, then assist the patient, give verbal cues that she is doing the wrong thing. This is just basically doing the patient's daily routine, specifically those that are affected with his current injury. So this one would be donning and doffing for lower extremity dressing. So ma'am, with a current injury right now, it really has a great impact, a negative impact as to how you walk and how you do things with the use of your leg, specifically your affected leg. So the reason behind it is because the muscles responsible for lifting your foot from the floor has been affected, has been impaired. It's because the nerve responsible or supplying to those muscles have been compressed. So if there is compression on the outside part of your leg, so it would really result in this, specifically if the compression is for a prolonged period of time, compression or any pressure at all. So it is one of the risk factors for this injury, but you don't have to worry because your injury is not permanent. And also if you're wearing a cast right now, you really need to learn on how to wear them properly, making sure that you check the skin around your cast or the skin on the leg in which your cast has been applied on. You need to check it every now and then, and if you observe any unusual signs or if you feel any unusual feelings, you need to contact your primary care physician immediately.
Okay, so we move on to the next topic, the posterior fossa syndrome, or also known as popliteal fossa entrapment. This involves the tibial nerve. So, the tibial nerve is a larger terminal branch of the 2 main muscular branches of the sciatic nerve. So, this provides innervation to the muscles of the lower leg, specifically triceps surae, plantaris, popliteus, tibialis posterior, flexor digitalis longus, and flexor hallucis longus. So, at the foot level, just after the heel, the tibial nerve divides into the medial plantar nerve and the lateral plantar nerve. The MPN supplies muscular branches to the big toe and 2 toes next to it, and the LPN the other 2 toes. The cerebral nerve is a cutaneous branch of the tibial nerve that supplies the skin and other legs and feet. So, popliteal fossa entrapment. So, the tibial nerve is compressed as it passes through the popliteal fossa. It is usually caused by a Baker's cyst. So, enlarged cyst may also compress the common term peroneal and cerebral nerve. Other causes are perforation in the synovial tissue in patients with rheumatoid arthritis. So, the patient presents with incomplete flexion of the knee joint and pain behind the knee or in calf muscles when the foot is dorsiflexed. So, the gastrocnemius, the tibialis posterior, flexor hallucis longus, flexor digitalis longus, and the intrinsic muscles of the foot, except for the TTP, are weak or paralyzed. So, the entire plantar surface of the foot is hypostatic or anesthetic. So injury to the tibial nerve can cause motor loss and altered sensation and pain to any areas it supplies depending on site of involvement and may occur due to space-occupied lesion, entrapment, laceration, dislocation of the knee, fractures of the tibia and fibula, and trauma. Okay, so now we will be doing neurological assessment, specifically the superficial sensation. This is to determine if the patient has or feels anything or has impairments of sensation. So first is the pain sensation. So you want the patient to tell you that he or she feels any pain, sharp or dull pain. So, sir, with this muna siyang pain, sir, muna siya sharp, muna siyang dull. So, when I put this, sir, muna kung sharp or dull na-feel mo. Okay, so start na, sir. Okay, so, okay, sharp, dull. Okay, sharp, dull, sharp, dull, sharp, dull, sharp, dull, sharp, dull. Okay, sharp, dull, sharp, dull, sharp, dull, sharp, dull. Okay, sharp, dull, sharp, dull, sharp, dull, sharp, dull. Okay. Okay, posterior fossa. Okay. Next is hot and cold temperature. So you let the patient inform the patient that you will be letting her or him feel hot and cold. So mag-determine siya if hot or cold ang may touch sa iya. So kung siya, hot na siya sir, and naman siya cold. Okay, so hot and cold, hot and cold. Okay, hot, cold, or hot, cold. Kaya siya sir, hot or cold, hot or cold. So hot or cold, hot or cold. Okay, hot or cold, hot or cold. Okay. Next is soft touch. So soft touch is you let the patient again determine if soft ba or not ang may touch sa iya. So soft, yun siya. Down, okay, soft, down, okay, soft, down, soft, down, okay, soft. Okay, ano siya. And then deep pressure. Pressure. Okay, pressure. Okay, pressure. That is it for neurological assessment. That is it for neurological assessment. Okay, so now we move on to range of motion. Measuring the range of motion of the lower extremity. So to start, we will need to inform the patient that we will be measuring the range of motion and we will be using the goniometer. So first, we instruct the patient to lie down in supine position, and what you're going to do is allow the hip to be flexed, the hip, and next is knee flex like this. And so the positioning of the goniometer is the fulcrum is at the lateral epicondyle of the femur, and the stationary arm is aligned with the greater trochanter, and the moving arm is aligned with the lateral malleolus. So may bend mo the knee flexion. So knee flex na sa patient. Follow na. Okay. Alright. Next is knee extension. So the knee extension is since normal siya, back to normal, back to zero ang knee extension. So from here to here. Okay. So next is ankle. Let's move on to the ankle. So for the ankle dorsiflexion, test the patient in. So next, we move on to range of motion of the ankle, which is the dorsiflexion and the plantarflexion. So for the position of the patient, ask the patient to be in the prone or lie on her belly. So the action here is to let the knee be flexed first and stabilize it like that. And so when you do the dorsiflexion, the positioning of the goniometer is the stationary arm is aligned with the fibular head, and the fulcrum is in the lateral malleolus. The moving arm is aligned with the MTP, metatarsal. Okay, so you dorsiflex the ankle like that, dorsiflex like that. Okay. So next is the plantar flexion. So for plantar flexion, the patient is supine. Okay. So with that, the patient is supine, the knee is extended, and so the fulcrum is in the lateral malleolus, and the stationary arm is aligned still in the fibular head. So when you do the motion, no. Okay, that's a flexion. So when you do the plantar flexion, padong sa, okay, padong sa, okay, padong sa, okay. So for the next is the ankle inversion and eversion. So the patient is in supine. So ask the patient to turn the foot in like that. Foot in. And so you put the goniometer here, and then you measure the inversion. You measure the amount of inversion. So same goes with inversion. The patient is in supine. The patient is in supine, and then ask the patient to turn the foot up. And the stationary arm is along the tibia, and the fulcrum is in front of the ankle. So that's it for the range of motion. So now we move on to NMT for the ankle dorsiflexion and ankle plantar flexion. So with ankle plantar flexion, if the patient is able to stand, you ask the patient to stand and instruct the patient to raise his or her heel or do a tiptoe action. Pakintohon. So when you kinto ang patient, patient is asked or instructed to do a tiptoe or heel raise as many as they can. Okay, one patient. So a grade 3 if a patient completes one heel rise correctly. So for grade 2 or grade 4 or lower, the patient is asked to do a prone and hang the patient, hanging. And so you do, so to test is, test if plantar flexion ankle is through the available range of motion. Manual resistance is down and forward towards dorsiflexion. Okay, so for grade 1, trace, you check for any muscle action in plantar flexion and the tendon. Okay. So for dorsiflexion, the patient is in seated position while the foot is in your lap. So you instruct the patient to bring your foot up and in. So dorsiflexion and inversion. Okay, so bring your foot up and in. So up for dorsiflexion and in for inversion. Okay, so grade 3 for that. For grade 2, you find it complete. For grade 2, this only completes a partial range of motion. So for grade 1, a palpable contraction. Okay, so now we will be performing the SLR2, so with this nerve bias to the tibial nerve. So first what you want to do is lie the patient in supine, and then have the hip flexion, and then the knee is in extension, and then the ankle is in dorsiflexion, and the foot is in the eversion, and the toes is in the extension. Okay, so hip flexion, knee extension, ankle dorsiflexion, foot eversion, and then toe extension. Okay, that's it for the SLR2 with the nerve bias of the tibial nerve. So now we move on to the plan of care. So for this plan of care, we will be doing ice packs to the popliteal to decrease the pain and inflammation. So pretend it is an ice pack. You fold it there, like that. And then you put it in the popliteal of the patient for 15 minutes. Okay, so you check on the patient. Okay, so So, you check for the patient. So, ma'am, next is we will be doing the hot moist packs. So, the hot moist packs is you put it in here. And you put it towards the calf. So, towards the calf, to decrease pain and provide relaxation of muscles and nerves for 20 minutes. So, just check for the patient. So the patient is supine, then moves the knee into flexion, and then raises the knee into extension upwards and making sure the foot is pulled back or dorsiflexed or pronated. And so, you can also do this in seated. Okay. So the patient is in long sitting position, starting from the flex on affected leg, and moves into knee extension and pronation. For the integumentary assessment, the therapist can put the patient in a supine lying position with the legs elevated on a pillow for better assessment. So here the therapist will inspect for any presence of wound or if there is swelling in the ankle and foot. So here the therapist can also palpate the area behind the medial malleolus or at the Achilles tendon. So upon palpation, the patient might feel pain and there is tenderness in this area since the tarsal tunnel is situated in this area. So pain and tenderness might indicate that there is compression of the nerve behind the medial malleolus or in the tarsal tunnel.
So sir, what you will do next is range of motion. This is to test your ankle joint motion. Sir, what I want you to do, sir, is to point your toes in my count. 1, 2, 3, go. Okay, next sir, I want you to point your toes towards the ground. 1, 2, 3.
Now we're going to assess the range of motion of different toe motion. So we're going to assess the toe flexion, toe abduction, toe adduction. So since I don't have a patient as of the moment, I'll just be telling you what the therapist should do during the assessment. For the measurement, the therapist will instruct the patient to keep the ankle in neutral position, so assuming the ankle is in neutral position, and then you instruct the fulcrum of the goniometer will be put here on the medial side of the metatarsophalangeal joint of the big toe. Do the proximal arm here and the distal arm here. Then you ask the patient to bend the big toe, bend it down, and you measure the flexion motion. So in tarsal tunnel syndrome, there would be limitation of motion on the toe flexion. Now we're going to assess for the toe abduction and adduction. So the patient can still be in sitting or supine position. So you can rest the foot on the bed. So the fulcrum will be at the dorsal aspect of the MTP joint with the proximal arm at the dorsal aspect of the metatarsal and distal arm at the dorsal aspect of the phalanx. So you ask the patient, so you measure it by moving the big toe towards the midline. So there. So that's for toe abduction. For toe adduction, you can measure this by from the abducted position, you measure again back to its original resting position. So that's for toe abduction and adduction.
So now sir, we will do the manual muscle test. This is to test your big toe and your other toes muscle strength. I want you to do, sir, kay i-bend imuhang big toe towards my finger and don't let me straighten it, okay? 1, 2, 3, go. Okay, now sir, I want you to bend your toes over my finger and don't let me straighten it, okay? Go.
I'm going to assess the hallux and toe PIP and DIP flexion for the manual muscle test. So here, this targets the flexor digitorum longus, flexor digitorum brevis, and flexor hallucis longus. So the patient can be in a sitting position, and the therapist will hold the foot. So the one hand of the therapist will prevent stabilization at the plantar surface, so here at the PIP or DIP joint, and one hand will provide resistance at the dorsal aspect. So the therapist will say to the patient, ma'am, I want you to curl your toes. Curl your toes, ma'am, while I provide resistance. So do not let me uncurl it. So the patient will try to curl toe. However, in tarsal tunnel syndrome, since there is weakness, the patient will not be able to fully resist the force given by the therapist, since there is weakness in the intrinsic muscles of the foot.
Next sir, what we'll be doing is the muscle bulk test. This is to test if there are any wasting in your feet to rule out some condition.
Now we're going to assess for the sensation. So in patients with tarsal tunnel syndrome, the superficial and deep sensation of the patient is affected. The therapist will assess the plantar aspect of the involved foot. So we'll begin with superficial sensation. So you'll say to the patient, ma'am, I'm going to assess for your superficial sensation. First, we'll begin with pain. So I have here the sharp end of the reflex hammer. So I'll be putting this on your skin and you see as if you feel the sensation. Okay, so you assess it with the patient's your foot and you tell me what temperature you feel. Is it cold? Is it hot? Okay. So we'll start with your eyes open and eyes closed, ma'am. Okay. Hot, cold, hot, cold, hot, cold. For like touch. So here, you say to the patient, I will say to the patient, ma'am, I have here the brush or reflex hammer. I'm gonna brush the sole of your foot. Then you tell me if you feel anything or if you feel anything, ma'am, ha? With the eyes open first and eyes closed. Then brush. The patient might say no. The therapist will say to the patient, ma'am, we're gonna assess for the pressure. So I have here the dull end of the reflex hammer. I'm gonna push it on your foot. Then you tell me if you feel sensation, ma'am, ha? So feel this, ma'am? No. Yes. No, like that. Now for the deep sensation, it is also affected. So here, you will say to the patient, ma'am, we're going to assess for your deep sensation. So first with your kinesthesia. And here, ma'am, I want you, what we're going to do here, ma'am, is I'm going to move your toe, your big toe, at a certain direction. Then you tell me where the toe is moving. The therapist will move it. So while moving, the patient will say the direction. So up, down, right side, left side. Next is proprioception. So here, the therapist will instruct the patient, ma'am, I'll be moving again, your toe, in different direction. Then you tell me the position of the toe, ma'am, ha? Is it upward, downward, left side, or the right side? Okay, so the therapist will move up, down, right, left. Next is for vibration. So here, you instruct the patient, ma'am, I have here a tuning fork, and then I'm gonna ring this and put this on the bony prominence of your toe. So let's say here, the dorsal aspect of the MTP joint. And you tell me if you feel any vibrating motion, ma'am, ha? Okay? So, like that.
Next, sir, we will be testing your sensation to know if you have impaired sensation and to know to which extent your impairment is, okay? So I will be introducing you two types of sensation. This is the soft sensation and this is the dull sensation. Okay, so ingnan ko nimo if pila ka gupi mo na feel, isa or duha. Okay? I want you to close your eyes, sir, and then ingnan ko if isa or duha mo ma-feel, ha?
Isa, dua, ta.
For the gait analysis, patients usually present with excessive pronation or supination, outgoing, excessive inversion, eversion, and antalgic gait pattern.
Next, sir, I will be doing a special test called the Tinel sign or the Hoffman-Tinel's test. This is to know if you have a tarsal tunnel injury, okay? So I will be tapping your anterior tibial nerve, and then if na pain or numbness, ingnan ko, sir, okay?
Okay.
Now I will be tapping your posterior tibial nerve.
A special test that can be used to assess for tarsal tunnel syndrome is dorsiflexion eversion test. So here, the ideal position of the patient should be in side-lying position, and the lowermost extremity, that is the tested extremity. So like that. So in this position, the posterior tibial nerve is very accessible. So in this test, the ankle of the patient will be maximally dorsiflexed with the toes in extension. And after that, you invert the ankle. So the dorsiflexion and inversion can put compression on the posterior tibial nerve. And you can also palpate the posterior aspect. So the result for this is that there will be exacerbation of symptoms and there will be tenderness upon palpation, thus signifying affectations of the tibial nerve and confirmation for tarsal tunnel syndrome.
So next special test, sir, I will be doing the triple compression stress test. I will be applying pressure for 30 seconds in your posterior tibial nerve. And then if there is tingling, sensation, or pain, you tell me, okay, sir? Start to, sir, ha?
Another special test or sign that we can do to determine if the patient really has tarsal tunnel syndrome is the Valix phenomenon. So here, the therapist will palpate the area behind the medial malleolus, and then upon palpation, there is tenderness and pain, and it runs along the proximal course of the tibial nerve. So this indicates that there is affectation at this certain area, and there is compression of the tibial nerve in this area.
For the outcome measures, first we have the short form 36 or SF36 health survey. This is used as a measure of a person or population's quality of life and comprises 36 questions which cover 8 domains of health. This is the form which they would answer.
For the outcome measures, we can use foot function index to measure the impact of foot pathology on function in terms of pain, disability, and activity restriction. So here, the therapist will ask the patient how the foot pain has affected the ability of the patient to manage activities of daily living. The therapist will ask the patient to rate the pain from 0, meaning there's no pain at all, to 10, meaning that's the worst possible pain ever felt. So here, the therapist will ask the patient several questions like, ma'am, do you feel any pain in the morning upon taking your first step?
And then when walking, when standing, and how is your pain at the end of the day, and how severe is your pain at its worst.
Now for the difficulty aspect, the therapist will ask the patient how much difficulty did she experience over the past few days. So from 0, meaning there's no difficulty at all, to 10, meaning that's so difficult that the patient isn't able to do the activity. So the therapist will ask how much difficulty do you experience when walking in the house, when walking 4 blocks, when walking outside, when climbing stairs, when descending stairs, when standing tiptoe, when getting up from a chair, when climbing curbs, and when running or fast walking. Now the therapist will ask the patient how much of the time did the patient do something or use a device. So from 0, meaning none of the time, to 10, meaning all the time. So the therapist will ask how much of the time did you use assistive device indoors, such as cane, walker, crutches, etc. Next, how much of the time did the patient use an assistive device
is the foot health status questionnaire. This is just a self-perception of foot health related to quality of life. This is an example of what they would answer.
For the intervention, first we have ice pack to be applied on the inside of the foot or the plantar surface for 20 minutes. So this is to reduce inflammation and pain on the foot. Here. So the patient will be in supine position like that, and with the ankle, lower leg resting on the pillow. So the therapist will apply the ice pack on the inside of the foot and ankle. There.
So now, sir, what we will be doing is the post-ultrasound on your foot. This is to relieve your pain. We will do this for 5 minutes. Okay, ra, sir?
Yes.
Mag-start ko, sir, ha? Wala ra sakit, sir. Dili ra katol.
The next intervention is antiphoresis with lidocaine medication and water solution with 2 milliampere current to be administered for 20 minutes. So this is to relieve the foot pain. So the foot is put inside the water basin, and the water covers all the surfaces of the foot with the electrodes surrounding the basin.
Okay, next, sir, we will be doing the interferential current therapy. This is to relieve your pain as well. We will do this for 20 minutes. Okay, sir? Okay, ra, sir?
Yes.
The next intervention is cross-friction massage behind the medial malleolus. So this will be performed for 5 minutes and 2 sets. So this is to improve circulation, loosen the adhesion, and improve mobility of soft tissue structures. So the patient will be, ideal position is in supine with the ankle rested on the pillow. So the therapist will perform cross-friction massage here, behind here, on the flexor tendon. So
Next exercise, sir, we will be doing the passive range of motion and active range of motion exercises with a rolled towel on your Achilles tendon for 8 reps, 2 sets to maintain joint and soft tissue mobility. What I want you to do, sir, first kay ankle pump, sir. So, imo na siyang ana, up, and then down. Then, next kay ankle circle. So, mag-form ka og circle using your foot. Okay? Next kay ankle side to side. So, imo siya side to side. Sige, sir. Ikaw, sir. 1. Mag-start ta with ankle pumps. 1, 2, 3, go. Next, sir, kay ankle circles. And then, ankle side to side.
next is stretching exercises for 8 repetitions and 2 sets. So this is performed to increase the soft tissue extensibility and improve range of motion and flexibility. So first we have calf muscle stretch. So this is done with the patient in long sitting position. So we can use a belt here to stretch the calf muscle. So like that. So 8 repetitions, 2 sets, 10 seconds hold.
Next exercise, sir, is stretching exercise. We will do this for 8 reps and 2 sets. This is to increase your soft tissue extensibility and improve your range of motion as well as your flexibility. Okay, so ato i-stretch imong plantar fascia, sir. I want you to cross your legs, sir. Using your hand, I want you to pull your toes towards your shin. Kanin, manimong shin. Okay? Sige, 1, 2, 3, go.
Strengthening exercises for 8 repetitions and 2 sets. So this is done in order to improve the muscle strength and also the overall function of the ankle and the foot. So we'll perform heel raises. So this is to increase the strength of the tibialis posterior muscle as well as the intrinsic foot muscles.
So next exercise, sir, is the ankle resistance exercise using the red elastic TheraBand. So we will do this for 10 reps and 2 sets to strengthen your ankle musculature and improve foot and ankle motion. Okay, so let me sit, sir. So I can follow ko gunit, sir. So what I want you to do, sir, kay imuhang foot kay imo siya first imo na siya ibira while mag-move na imong foot, okay? Buhaton kay imo i-point imong toes padulong sa floor, okay? 1, 2, 3, go. Sunod kay padulong sa saas. Sunod kay padulong in, point towards in, okay? Sunod, sir, padulong na sa dito. So next sir, kay mo progress na ta to green, meaning mas kuan na siya of resistance. Okay sir? Mao ra gyapon imong himuon na action. 1, 2, 3.
All ambulation for 7 repetitions and 2 sets for gait training to improve leg strength and overall function.
So next exercise sir, kay you will do the balance training to improve your proprioception, ankle, foot, and lower leg strength and function. Okay, what you will be doing sir, kay you will stand on one leg for 3 times with 30 seconds hold per side. Okay, start out with your right. 1, 2, 3, go.
Other interventions include the use of UCBL, orthosis, in order to correct the hindfoot alignment.
Okay, so now sir, I will be giving you your home exercise program. So I will introduce you to the abbreviation RISE. What does RISE mean? R is to rest your foot and stop putting pressure on the affected area. And then for I, you have to use ice pack to the inside of your ankles and foot for 15 minutes to reduce inflammation and pain. So kani siya sir, example niya siya sa ice pack, imo ibutang sa imuhang foot, sa imong ankle, okay?
Okay.
Home exercise program include compression by wrapping the foot with an ACE wrap in order to help reduce inflammation and ease pain. Also, elevation of the foot above the heart level of the heart using a pillow when in long sitting or in supine position.
Okay, sir, so now I will be reminding you to wear an appropriate footwear to avoid tight-fitting shoes and also to pay attention to how you run and to avoid those motions na muko sa symptoms sa imong tarsal tunnel. Okay? You have to also focus on gentle movements to reduce irritation in your ankle.
Further precaution, if pain persists, especially in the ankle and the foot, immediately stop the exercise and take a rest. And also contact the physician if pain still continues to persist. Avoid trying to do too much too quickly to give adequate time for the ankle to heal. And lastly, do not overuse the foot, such as in prolonged standing, walking, or exercising.
Trigeminal neuralgia, also known as tic douloureux by Nicholas Andre, Fotherhill's disease by John Fotherhill, or suicide disease. It's usually characterized by intense, short-lived spasms of pain of the lower portion of the face, such as the jaw, the cheek, and the nose is not affected, but they feel like electrical shocks followed by a steady dull ache on the trigeminally innervated areas of the face. Triggered by vibration, contact with the cheek, such as when shaving, washing the face, or applying makeup, brushing the teeth, eating, drinking cold water or hot water, talking, or being exposed to the wind. So, mode of injury is associated with multiple sclerosis. So, approximately 1 to 2% of multiple sclerosis patients develop TN. Other associated pathologies are Charcot-Marie tooth disease, which is a hereditary motor neuron neuropathy, compression of blood vessels near the trigeminal nerve, injury to the trigeminal nerve sometimes result of sinus surgery, oral surgery, stroke, or facial trauma. Diagnostic tests involve magnetic resonance imaging, MRI scan. Diagnosis of classical trigeminal neuralgia may be supported by an individual's positive response to a short course of an anti-seizure medication. Observed usually unilateral, predominantly on the right side, occurring on the areas of the face where the trigeminal nerve supplies, so the cheek, jaw, teeth, gums, sometimes eyes, and forehead. Pain episodes described as stabbing, electric shocks, or exploding pain. Frozen or mask-like face. Pain is triggered by triggering the trigeminal nerve supplied areas with light touch, vibration, and light pressure. So the integumentary assessment is palpation. So we palpate on the trigeminally nerve innervated areas of the face. So there is sensitivity there, and the patient usually winces because it triggers the pain. Neurologic assessment is for superficial and deep sensations, for pain, light touch, temperature, and pressure vibration. So patient usually is highly sensitive to these sensations. They're using the sharp end of the reflex hammer and the dull end, using the soft brush for light touch, and pressure from the patient's fingertips. So for the pain, it's the sharp end and the dull end of the reflex hammer on the trigeminally innervated areas such as the cheek, jaw, and the forehead. We ask if you feel this, and here. How about this? Do you still feel dull? The dull end? And we ask them to determine which
which sensation they feel, dull or sharp. Next is we lightly brush on the areas, and then for pressure, we apply just light pressure on the areas. For temperature, we use hot or cold tips of the test tubes. For this is hot, so do they feel the hot sensation, and this is cold, do they feel the cold sensations. Cranial nerve testing of the cranial nerve number 5. Patient is unable to close eyes tightly, smile, show teeth, whistle, puffs, cheeks to trigger pain. Posture is the patient has stiff, static neck posture to avoid trigger pain. The functional assessment is an inability to do self-care activities due to triggering pain, such as hygiene, eating, self-adjusting of the upper extremities, because when putting on a shirt, it usually hits the face, so that triggers the pain. A problem list comprises of pain on the right side of the face, such as the cheek, jaw, and forehead, mask-like frozen face, heightened sensitivity of the face, decreased functional capacity in terms of self-care activities to face and upper extremities. Medical management or pharmacological management comprise of anti-seizure medications or anticonvulsants, or such as carbamazepine or oxycarbazepine. When used in the early stages, these drugs are generally effective in reducing pain of the affected individual. Sometimes muscle relaxant such as baclofen is used in conjunction or alone. So surgical management, this is done when medication is not enough to control pain. So a rhizotomy causes sensory loss and facial numbness, but severe forms of rhizotomy are available to treat trigeminal neuralgia. So a balloon compression works by injuring the installation of the nerves that are involved with the sensation of light touch on the face. The procedure is performed in an operating room under general anesthesia. Glycerol injection is generally an outpatient procedure in which the individual is sedated with the intravenous medication. A thin needle is passed through the cheek next to the mouth and guided through the opening on the base of the skull where the third division of the trigeminal nerve, alveolar division, exits. So a radiofrequency thermal lesioning, also known as RF ablation or RF lesion, is most performed in outpatient basis. The individual is anesthetized, and a hollow needle is passed through the cheek through the same opening at the base of the skull where the balloon compression and glycerol injections are performed. Also, stereotactics to reduce surgery, such as the gamma knife or cyber knife, uses computer imaging to direct highly focused beams of radiation at the site where the trigeminal nerve exits the brainstem. Other supplementary treatments are acupuncture, upper cervical chiropractic practice, biofeedback, vitamin therapy, and nutritional therapy. Some people report modest pain relief after injections of botulinum toxin to block activity of sensory nerves. Plan of care comprises of infrared radiation therapy, so near IR luminous light on the trigeminal nerve innervated areas of the right side of the face at 350 nm, frequency of 4x10, 14 Hz for 10 minutes to relieve pain, promote muscle relaxation. So patient is placed supine with the head supported on a pillow. Body is draped from the lower extremity up to the upper chest. Patient wears anti-radiation goggles. Desensitization exercises using a cotton wool to be stroked on the painful area for a few minutes per day, progressing to several times per day as the skin and tissue adapts to the increased strength of the stimulus. So cotton wool is stroked. This is to retain the skin and superficial tissues when there is hypersensitivity. Next is deep breathing exercises such as diaphragmatic breathing exercises done for relaxation techniques, done for 5 inhale-exhale cycles for 2 sets. Lastly, isometric neck exercises to promote good blood circulation. So neck flexion done passively with a therapist behind the patient. So there is neck flexion, neck extension, lateral flexion, and rotation. Home exercise programs, it's with the warm washcloth apply to the face for relaxation for 10 minutes. Also with the desensitization exercises with the cotton wool cloth, the deep breathing exercises, and the isometric neck exercises. Patient education comprises of pain management, diet plan, modified ADLs such as advice on how to avoid using cold water for drinking and washing their face, but also chewing with the non-affected side, trigger pains, and how to alleviate them.
So now we proceed to the cranial nerve 11 injury or the accessory nerve. So CN11 is also known as the accessory nerve, and the cranial roots could be considered as part of the vagus nerve, CN10, when factoring in the function of the two nerves. So both the cranial roots of the accessory nerve and the vagus nerve originate from nucleus ambiguous and the dorsal nucleus of the vagus nerve, and they both travel to the laryngeal muscles, supplying the laryngeal muscles motor fibers. So as the accessory nerve travels down and away from the brain, the cranial and spinal pieces of the nerve come together to form the spinal accessory nerve. So the sun exits the skull through the jugular foramen and descends alongside the internal jugular vein, coursing posterior to the styloid process, posterior belly of the digastric muscle, and the sternocleidomastoid muscle, or the SEM, before entering the posterior cervical triangle. So it travels to the SEM, either superficial or deep, and then it enters the trapezius muscle, where a major trunk of the accessory nerve converges with C2, C3, or both. So the traveling pathway of this nerve, as what I've explained earlier, provides a functional significance to the structures in the posterior neck. However, because of the long and superficial nature, the accessory nerve is prone to injury. So the innervations, again, in addition to spinal motor distribution to the SEM and traps, the spinal accessory nerve provides laryngeal and cranial innervation. Therefore, if there's compression in the jugular foramen, this can affect the spinal accessory nerve, causing dysphagia, hoarseness, and dysarthria. And so these are some of the differential diagnoses that diagnosed with spinal accessory nerve injury. So long thoracic nerve injury causes weakness or paralysis in the serratus anterior and also presents with winging of the scapula and is worse with lift forward flexion of the arm or pushing the outstretched arm against the wall. This is different from CN11 injury because the winging of the scapula is with abduction of the arm. So rotator cuff injury has a similar presentation when lifting the arm behind the head, except there is no winging of scapula in rotator cuff injury. For the examination, first is for the chief complaint. Mostly there is pain and weakness involving the shoulder that radiates to the upper back, neck, and ipsilateral arm. And pain is exacerbated with weight on the injured shoulder without being supported. So for MOI, for this injury, surgery along the structures of the neck, lymph node biopsies, carotid surgeries, cosmetic surgeries, it can cause aggravation towards the spinal accessory nerve. Then also with trauma, then stress exerted on the neck due to prolonged positioning, and acromioclavicular joint dislocation, which affects the SEM. So for diagnostic tests, we have high resolution ultrasonography, or HRUS. It's basically a form of ultrasound, and then other electrodiagnostic tests. So now we proceed to the O part. Sir, I am James and I will be your PT for today, sir. For the first part, I will be observing you, sir, and checking if I can see any deviation or any problems in your body. Okay. So upon observation, there is noted asymmetry with the SEM on the affected side. Then also there is noted ipsilateral scapular winging, so on the affected side, and also there is the shoulder of the patient is depressed on the affected side. Okay, sir. So thank you, sir. Karon, sir, mag-perform ko palpation, sir. So I will be touching certain parts of your body, sir, to check if there is pain or kanang mga hubag-hubag, sir. Okay, okay, sir. Sige, sir. Okay. So tell me, sir, if you feel any pain. Dili, sir. Sakit, dili, sir. Okay, so there is noted pain on the affected shoulder. So what I will do, sir, is I'm going to assess your range of motion. So basically, how far your shoulder moves, sir, no? Okay, mo may mga condition naman sa mga shoulder. So will you allow me to start, sir? By the way, sir, this is the goniometer, and I will use this to check your range of motion, sir. So pwede na mag-start, sir. Sige, start with the side, bata. Okay, so I will be assessing your shoulder abduction. So basically, sir, from the midline, I want you to move your shoulder here, your arm, okay? Ano, sir, ha? Sige. So okay na, sir, can you start? Sige, sir. Ready, sir? Okay, when I say go, move, sir. 1, 2, 3, go. Sige, sir. Move, okay. Okay, very good. Morning, sir. Morning, mga makaya, sir. Okay. Proceed to cervical rotation and lateral flexion. So imagine that the patient is at front. So sir, karon sir, proceed. Itong buhaton, sir, is ang motion is from here, move ka padung dihan, sir, ha? That movement, sir, ha? Sige, sir, I will be using the goniometer. Okay, when I say go, sir, move, sir, ha? When I say go, ready. 1, 2, 3, sige, go, sir. Turn yung head. Sige, sir. Turn. Okay. Morning, mga makaya, sir. Okay, sige, sir, very good, thank you. So now proceed with lateral flexion. So anong yung position, sir? So sir, what I want you to do is from this position, I want you to move here, to turn your head here, ha? To tilt, sir, tilt your head here, okay? Sige, sir. Then I will use the goniometer. Ready, sir? When I say go, I want you to go, ha? Sige, ready. 1, 2, 3, go. Sige, sir. Iko yung mga head. Okay. Okay. Ano na yung makaya, sir? Okay, thank you, sir. So first, we test your SEM na muscle. So what I want you to do, sir, is basically, provide cogs resistance here, then I want you to turn your head padung dito, sir, ha? So i-contract ko resistance, sir, okay? Practice to, sir, ready? 1, 2, 3, go, na motion. Okay, kana, sige, sir, ha? So, provide resistance, sir, ready? 1, 2, 3, go. Sige, try to turn and resist, sir. Hindi rin makaya, sir. Okay, sige, sir. Now we proceed to the trapezius. So upper taps, face dito, sir, ha? So what I want you to do, sir, is I want you to try to elevate yung shoulder pataas, sir. Then muhatag resistance going down, sir, ha? So I want you to try to lift your shoulder. Sige, sir, ready? 1, 2, 3, sige, go. Lift your shoulders and muhatag resistance. Para rin makaya, sir. Okay. Sige. Pero sir, higda ta. Okay. So from this position, sir, support ko sa imong hindi pull back ang imong kuan, sir. Dire na sir. Imong i, so when nakita ka, sir, i-try mo pull back ang imong arm, or bend, pull back ka sa bench, sir. Try to pinch ang imong back nila, sir. Okay. Muna for middle, sir. Nato buhaton later. Kay katong imbis katong angle, isa ka na to gamay ang imong arms, then kato try to pull back or squeeze. Imagine squeezing a hook sa imong back, sir. So muna ay middle tap, sir. Kato kang or 90 degrees ang imong elbow, then pull back. If may lower taps, isa ka gamay imong arms, sir, and then try to pull back. Get, sir? Sige. Sige, sir. So Hindi na, sir. Okay, sir. When I tell you to go katong middle tap, sir. Ready? 1, 2, 3, go. Sige, middle tap, sir. Okay. Ano, sir? Right distance. Okay. Ano yung sir? Okay, good. So, karon, sir, proceed sa lower tap, sir. So, saka gamay mo shoot yung arms, then pinch. Sige, 1, 2, 3, go. Sige, pinch your back. Ano yung sir? Okay, sige, sir. Now, we proceed to the cranial nerve testing lang. Okay, neurologic testing. So, sir, what I want you to do is, I want you to try to swallow, sir. Sige, when I say swallow, 1, 2, 3, go. Sige, swallow. Okay, very good, sir. Kaya na. So, try to speak, sir. Okay, so okay, sir, no? Normal lang tone yung voice. Okay, thank you, sir. Okay, so lastly, sir, we proceed na to functional na testing. So, I want you to try, kanya ko arm, sir, no? So, I want you to try reaching my arm. Sige, sir, ready? 1, 2, 3, go. Try to reach. Dili mo mabot, sir. Sige, sir, sige, balik na. Sige, again, 1, 2, 3, sige, try to reach. Dili mo mabot, sir. Okay, sige, sir. So, now we proceed. So, that was for the O, now we proceed to the problem list. That was the O part, and now for the problem list is pain on the shoulder or the upper back, limitation of motion on shoulder abduction and flexion, and cervical rotation and lateral flexion on affected side. There is also decreased muscle strength of upper, middle, and lower trapezius and SEM, and possible anterior deltoids of the affected side. There's also scapular winging in abduction on affected side, atrophy of the shoulder musculature on the affected side, and of course decreased functional capacity in terms of overhead reaching on the affected side. And now we proceed to the plan of First off, we have the NMS or neuromuscular electrical stimulation. This is for us to facilitate your muscle contraction. Okay, sir. So mag-start ako, sir. Okay, see, face dito, sir. Okay, so yung affected area is left side. So ako yung electrode, sir. Sa mga upper taps, sa mga lower taps, and then provel ko, Okay, sir? So, ako set ang parameters to 50 pulses per seconds, on 10 and off 50 seconds. So, start na siya. We'll be doing this for 20 minutes, sir. Okay? Okay, sir? So, okay, sir, wala kami na-feel any problem. Okay, so now we proceed. This exercise is active assisted range of motion shoulder elevation. So the patient will try to lift his or her shoulder with this side assisted by the therapist. So sir, buhaton sir ha, 5 reps and 2 sets with 5 seconds hold sa mabaw. So you ready? 1, 2, 3, go. 1, 2, 3, 4, 5. Again. This side assisted by the therapist. 1, 2, 3, 4, 5. So next exercise is capillary PNF from anterior depression to posterior elevation. So instruct the patient to place his shoulder down and in, and afterwards up and out. So sir, again sir, down and in, up and out. So perform this with these parameters. So this is to increase scapular and shoulder motions. Next exercise is muscle setting with affected SEM. So try to place your hand on the patient's cheek, then ask him to lean towards your cheek while maintaining resistance. Okay? So sir, try to lean sa ako ang hand siya. So sa taling button sir, for 10 reps, 2 sets with 5 seconds hold. Sir, 1, 2, 3, go. 1, 2, 3, 4, 5. Then allow the patient to feel the muscle contraction. Again, 1, 2, 3, go. 1, 2, 3, 4, 5. So next exercise is strengthening exercises to shoulder abductors and shoulder depressors. So ask the patient to hold a 5 pound weight. So, ma'am, sir, what I want you to do is I want you to try to lift your weight, try to lift the weight, sir, then go sideways. So we perform this with 10 reps and 2 sets. 1 until 10. So next is shoulder depressor. So same, ask the patient to hold the weight and try to pull his arm down using the weights. So the next exercise is scapular mobilization with the affected side. So with the patient inside lying, ask the patient to elevate his arm. So while the therapist places manual contact with the patient's scapula and guide the scapula to perform the motion. So sir, try to lift yung mga arm siya. So when the patient lifts his arm, the therapist provides manual contact to the scapula to support the shoulder elevation. So we do this with 10 reps and 3 sets. Okay sir, sige again sir. 3, go. Next exercise is wall slides for 10 reps and 2 sets to improve the patient's muscle strength in his shoulder abductors and shoulder flexors. So imagine that this is a wall. So instruct the patient na, sir, try to raise your hand without moving your tongue sir. So try to raise your arm without moving. Sige, perform sir. 1, 2, 3, go. Raise your back sa wall sir. Okay. For functional reaching exercise, we do this for 10 reps and 2 sets. So ask the patient to try to reach your hand. So sir, try to reach now sir. Okay. So while the patient tries to reach the hand, you perform a manual contact to the patient's scapula. So sige sir, try to reach sir. 1, 2, 3, sige, reach. Okay, very good. Other side sir. Okay, very good. Then sige sir, balik tayo affected na side. Sige sir, try to reach. Okay. So hello sir, welcome to ang nanong care sir no? So I will be giving you home exercise program sir, para you can do this at home. So kato to wall slide, ganyan sir, kato to buhaton, 10 reps and 2 sets. And lastly sir, our shoulder shrugs. So you simply just have to try to raise your shoulders sir. So do this for 10 reps and 2 sets sir. Sige daw. Okay, so you go sir. Okay, so thank you sir. See you sa the next treatment session.